Good afternoon, everyone. My name is Stephanie Rocha. I'm representing AEACaP, the Spanish Association of Lung Cancer. I'm very pleased to welcome you to this webinar. Today's webinar is about KRAS, lung cancer patients, and we are very happy to have Dr. Rosario García Campelo and Professor Alfredo Adeu collaborating with us to make it possible. Welcome to both of you. I do not want to continue without thanking all the people who are behind this camera listening to us and participating. Everything we do is for all of them. Thank you, Amgen, Bristol Myers, Squibb, Boehringer, Ingelheim, Roche, and Takeda for the great collaboration, because this action wouldn't be possible without them. Before introducing our speakers, I would like to talk about AEACaP. Created in 2008, it has recently been named as a public entity. Our association works for lung cancer patients and their families to have mechanisms to manage and cope with this illness from the beginning. AEACaP provides different activities to patients, useful informative activities like today's webinar, with a huge range of interesting topics, nutrition support, clinical trial research, scholarships. It also gives patients psychological support, legal support, Facebook and WhatsApp groups to share experiences. Action to improve awareness and prevention, promoting exercise with activity in different cities in Spain, a Pulmón climbing mountains, even a reading club and cultural activities. Everything for the patient, everything for our future. There are so many different activities. I could use this whole webinar to talk about them, but I'm going to continue. For those who have not connected before to our previous seminars, we simply would like to inform you that the objective of this meeting is to provide useful and rigorous information from experts such as the one we have today. Secondly, I would like to inform you that what we want is to solve any doubts you may have during your illness as a patient or in your environment. We have already received some questions through the means that we have made available to you, such as email and registration. Thirdly, I will explain the structure of the webinar. First, we will be able to enjoy the presentations for about 20 minutes each one, where we will be giving all the possible information on this topic. During this time, you can ask questions or doubts through the means mentioned before, which we will collect and discuss later after the presentations. We should start now with the topics of the seminar. We will begin with Dr. Rosario García Campelo, who is going to have current treatments in this mutation. I'm going to introduce her bio. Dr. Rosario García Campelo is the head of Medical Oncology Department, Thoracic Tumor Unit Chair in the University Hospital A Coruña, Spain, and head of Oncology Research Group, Biomedical Research Institute, A Coruña, Spain. Her current research focuses on the treatment of thoracic tumors with special interest in novel therapies against lung cancer and clinical translational research, with an active participation in national and international crisis trials. Please, Dr. García Campelo, we will be glad to hear your presentation.
Hi, good afternoon, everyone. Can you hear me well? Yeah?
Perfect.
Okay. And can you see my slides moving?
Yes.
Okay. So first of all, my deepest thanks to AEACaP. It's always a pleasure to share with you these kind of activities. I think they are really useful, and it's an honor to be here with all of you talking about this old target, but some kind new for us as a druggable target in the field of non-small cell lung cancer. So these are my conflicts of interest. I always think it's important to understand where we're coming from in order to see clearly where are we now, how fruitful has been all the way, the hard way for us professionals, for all the patients and families to reach what we have today. And this was our reality many years ago when I started treating non-small cell lung cancer patients. The platinum tablets was the way we have to treat advanced non-small cell lung cancer. And you can see the outcomes we got with this kind of approaches. And the truth is that median OS was quite poor, and the long-term survivors were really low. Today, we are living a different moment, completely different moment, thanks to many and great treatments, and also to the increased knowledge we have about this disease. I would like to start with this reflection. Cancer is a genetic disease, and it's a disease that probably creates a huge amount of chaos. We have many, many genetic alterations, and the truth is that still we don't know what is the real role of many of these alterations in terms of if we can treat them specifically, if they are very, very important, if they are not so important. We call them drivers or passenger mutations. And as I mentioned before, we know much more today about this disease, but still a lot needs to be understood. And when we talk about the concept of precision medicine, this is basically what we try to do in the field of lung cancer. We try to reorder the chaos. We try to move this black circle to this approach we have today. And as I mentioned before, this has been a huge effort during the last years. Today, fortunately, we have around 45% of non-squamous population. We can detect a genetic alteration, and we can offer a specific treatment according to that genetic alteration. This is one of the biggest steps in the history of oncology, and of course, in the history of non-small cell lung cancer. And I think all of us who do this kind of work every single day, we are truly believers in the concept of personalized medicine, because we have seen in many, many patients the benefit that means finding one of these genetic alterations and offering a specific treatment. And we have moved from these low outcomes we got with conventional chemotherapy to the incredible outcomes we have today with this concept of personalized medicine. And I want to be honest, still we are not curing the vast majority of the patients who have a genetic alteration. But really, if we try to remember the first slide, where are we coming from? Where are we now? I think these are wonderful news for all of us, patients, families, and physicians involved. Okay, let's say we are strong believers, okay, in the concept of personalized medicine, but what kind of believer can we be when we talk about personalized medicine? And I used to compare this idea with the football, the football world, okay? When we talk about personalized medicine, we have this kind of highly effective drivers, strong believers, like EFR, like ALK, like ROS, like RET, like ENTRAT. Probably I need to move BRAF from the moderate to this highly, because we have new approaches for BRAF nowadays. And then we have these moderate effective drivers, and probably KRAS is one of the best examples. KRAS is the oldest genetic alteration we know in the field, but is one of the newest we have in terms of having specific drugs for this specific patient population. And this is what we are going to review today. What is the role of KRAS as a driver, one of these genetic alterations that can produce cancer cells, the prevalence of KRAS mutations, the concurrent alterations that can coexist with KRAS, because KRAS is a very difficult target, as I will try to explain to you. What do we have today in the first line setting, and what are some new drugs we have for previously treated population, because the future, I will let this part for Dr. Adeo. So KRAS basically moves between active and non-active state. And the active state, and this movement serves as an on-off switch to regulate downstream signaling. Downstream signaling that is essential for this oncogenic effect. When we have a mutation in KRAS, like the mutation most frequently found in the field of lung cancer, KRAS G12C. When we have this kind of alteration, this mutation favors the active form and promotes the oncogenic signaling. So RAS is the most frequent alteration described in cancer. It can be present in different solid tumors. It can be so high as 80% in pancreatic cancer, for example, and so low as 5% in head and neck cancer. When we talk about lung cancer, 35% of lung adenocarcinomas harbor a KRAS mutation, 35%, compared to EGFR, compared to ALK, to MET, is the most frequent one. And KRAS is very heterogeneous. 40% of this KRAS mutation is KRAS G12C, the most frequent one. And this specific mutation is observed usually in smoking population, smokers, while other KRAS mutations like G12D are more frequently found in patients who never smoke. So it's not so simple as EGFR or as ALK. It's much more complicated. And the complication is not only because of this I am showing you, but because this alteration can coexist with many other mutations. It's not a clean genetic alteration. It can coexist, as I mentioned, with other alterations like P53, KEAP1, or STK11. And we are starting to understand that patients with these co-occurring mutations are different to patients who have just a KRAS mutation. Also, we have seen that, I don't know if you are aware, EGFR mutations are more frequently found in Asian population. It's the opposite when we talk about KRAS. This alteration is more frequent in Western population compared to Asian population. The testing is probably the first step when we talk about personalized medicine. Testing of KRAS is recognized in the European and also in the national guidelines, and liquid biopsy can also be useful to detect KRAS mutations, to monitorize the response after a specific treatment, and also to detect this coexistence alteration I was telling you before. How should we treat a patient harboring a KRAS mutation? Well, let's talk about those patients who didn't receive any kind of treatment when they come to our clinic, first-line setting, and they harbor a KRAS genetic alteration. Well, unlike other targets like EGFR, ALK, or ROS, KRAS per se is not associated with poor response to immunotherapy. Immunotherapy is an essential treatment today in the first-line setting, talking about advanced non-small cell lung cancer. And we already know that combining immunotherapy plus chemotherapy may be a useful tool to treat patients harboring KRAS mutations. Immunotherapy alone probably is not the best option for these patients, but immuno plus chemotherapy, or even immuno plus chemotherapy can be a very good option. And we also know that if we have a patient harboring KRAS and other alterations like KEAP1 or STK11, these patients can do well if we add an anti-CTLA-4, another form of immunotherapy. When we talk about targeted agents, well, we have a crowded landscape, and these are excellent news. Having options is always great news for patients and for us. Many of these options are still research options, but we do have available options I will try to comment very briefly. So these is one of the many lists you can test. You can check just focusing on different KRAS inhibitors. But we have other options to target these alterations. We can do KRAS inhibitors in monotherapy, but we can also combine, trying to overcome this complex pathway, KRAS inhibitors plus immuno plus chemo plus many other options. Talking about KRAS G12C, and if you remember, this is the most frequently genetic alteration when we talk about KRAS mutations. This is the list of KRAS inhibitors, specific drugs that target KRAS G12C that are in development. Today, we have two options that have been approved by FDA and by EMA. In Spain, we just have one approved, and it's sotorasib. And this is the results of the phase 2 trials that have tested these agents that block specifically KRAS G12C in previously treated population, not in naive patients. And the drugs are active. We can get response rate around 40% of our patients achieve a response rate. The duration of response is nice. And the median overall survival, you can see it goes from 12 to 15 months, 14.1 months. This is previously treated population. Well, these are phase 2. These trials didn't compare these drugs to conventional treatment. We have two phase 3 that compare the specific agents to the standard of care, both BRAID 200 and Crystal 12. Two positive phase 3 trials favoring the use of the personalized medicine, sotorasib, adagrasib, versus conventional chemotherapy. These drugs also have better tolerability compared to chemotherapy, and they have a positive impact in terms of quality of life. The toxicity of these agents basically is gastrointestinal toxicity, diarrhea, fatigue, nauseas, but it's quite low. The vast majority of the cases is grade 1 to 2, that is low toxicity. Grade 3 and 4 are the higher rates we use to classify toxicity adverse events related to our drugs. These two agents have been included in the European guidelines for patients who progress after one first-line approach. Usually, this first-line approach, as I mentioned before, is immuno plus chemotherapy. Well, these are the clinical trials. Clinical trials are not the reality because many patients cannot be included, but also we have real-world data. And the real-world data confirm that in patients who have been previously treated and progress, using one of these specific agents is better in terms of overall survival and in terms of progression-free survival. This is a very busy table. Forget about it, okay? The main message I want to give you from here is that we have new KRAS G12C inhibitors on development. They seem to be more active against the disease, and they seem to be less toxic than the two we already have approved. So we are improving. The same we have done in EGFR. We have first generation, second generation, third generation EGFR tyrosine kinase inhibitor. The same we are trying to do in KRAS. We started with these two drugs, but we are trying to improve with new agents. And this is how the future looks. And as I mentioned before, this is for Dr. Adeo. The future is amazing. We have I would say, almost every single approach you can imagine is being developed in the field of lung cancer. Many of us have these clinical trials ongoing, and the left side of the slide is probably the most new approaches. This is not our current strategy in our centers, novel immunotherapy approaches like T-cell receptor therapy or TILs. We have other KRAS. We have talked about KRAS G12C. as I mentioned before, we have other. A lot of work is being done in these specific others. They tend to be never smokers or light smokers. This is just an example of the many agents that are being developed for those other KRAS mutated non-small cell lung cancer. We need to deal with resistance, but it's the same for RAS, for EFR, for ALK. It's always there, resistance. So we need to try to understand why patients progress, why patients do not respond to a specific agent, and try to overcome that resistance mechanism. And this is basically good knowledge. And we need to have this knowledge in order to develop novel strategies for this patient population. So this is the oldest driver, but as I mentioned before, is one of the newest in terms of the capacity we have to treat these patients. And we have many challenges. We need to incorporate these advances in early stages. We need to understand how to deal with elderly population, with poor performance status. I talk about primary resistance, secondary resistance. To optimize the dose, this is something that worries a lot to all of us because quality of life matters. And as I mentioned before, for other patients, no KRAS G12C, we also need to offer better approaches. So this is where we are. We are getting a lot in the field, and hopefully the undruggable is getting druggable. And I may understand that you see the results and you say, wow, it's not so good as the other, but this is the beginning, okay? We are in the good, we are doing well, I think. RAS pathway is very complex, and I try to mention that this not only just one mutation is really complex, these genetic alterations. We have new inhibitors available for our daily clinical practice. These are excellent news, and we need to understand much better the biology of the disease, which combination approach for the near future, the commutations. We need to personalize the treatment of KRAS mutated non-small cell lung cancer. This is my last slide. I think it's time to optimism. The future is now, but we need to take into account that without testing, we cannot talk about KRAS mutated population. So testing is something that we need to keep in mind. Testing as much as you can. Access is always a problem. We have access to some of these agents, but we need to do much better. Toxicities, we as physicians, we need our learning curve also. Resistance, liquid biopsy is a wonderful partner. And I will say that be careful with the concept that more is better, because Dr. Adeo, I guess, is going to talk about a lot of combinations, but more is better if we can offer better outcomes for our patients with a good tolerability profile. Thanks a lot for having me, and happy to answer all the questions after Professor Adeo.
Thank you very much, Dr. Garcia Campello. It's been an amazing and very interesting and, of course, inspiring presentation.
Thanks a lot.
Now we are gonna to talk about progress in treatments and new therapies. We would like to welcome Professor Alfredo Adeo. Professor Adeo is the head of the Oncology Service in the Department of Oncology at the University Hospital of Geneva, Switzerland. His main research interests include circulating tumor DNA, liquid biopsies, predictive and prognostic biomarkers, and patient-reported outcomes in thoracic malignancies. Many of Adeo's writings within the field of lung cancer include non-small cell, include immune checkpoint inhibitors and oncogenic biomarkers such as EGFR, HER2, and PD-L1, and he has led of numerous translational research projects focused on tumor development and targeted therapies particularly. So please, Professor Adeo, whenever you are ready.
Thank you very much, Stephanie, and thank you very much, to all of you for the kind invitation. I hope you can see my slides. It's always the tricky question. You can see them, and I hope you can see them moving as well, which would be good. So let's start with the disclosures, and then let's crack on straight away with what we're going to talk about. I think Rosario has really set up the stage for really something really relevant, and it seems incredible now we're talking about what we thought it was undruggable, which is this famous KRAS G12C mutation. And as has been said already, the reason why it's so important for us, particularly for the Caucasian population, the European population, or the Western population, is that this mutation is relatively quite common compared to the Asian one. We already mentioned the mechanism of action. I'm not going to talk about it too much. And again, this has already been mentioned about the activity of the drug. So we know where we are. So we have the two drugs available in some country. And this is something else perhaps we should address as the difference in many countries. And an example I give to you is that at the moment in Switzerland, we don't have access to sotorasib. We used to have access, has been withdrawn after the ODAC from the FDA, so the Swiss Medic, which is the equivalent of the FDA of the EMA, has reviewed indication and withdraw sotorasib. Now we have access to adagrasib through an expanded access program. So you can see that there are discrepancy and inconsistency in different countries. Nevertheless, those drugs are certainly very relevant for our patient, has been already said. Again, it's very heterogeneous. When we say KRAS, we're talking about a very heterogeneous group of disease where there are different type of mutation. And that's why it's so important, has been already said by Rosario, that we definitely need to perform the test and go really as deep as possible to identify the specific subgroup that might benefit from a specific treatment, not just the KRAS per se, because within KRAS there are many different subgroup. Has been already mentioned these. And this is also very important, why we need certain panel rather than a KRAS PCR analysis, because there are co-mutation that might play an important role. It could be, as you can see, STK11, KEAP1 as marker 4, and not only perhaps resistance mutation, but they're also kind of indication of very aggressive type of cancer, and where we know we need to intensify the treatment has been shown quite consistently, as you can see from these for several publications, that the prognosis seems to be poor when there is a commutation STK11 or KEAP1 or marker 4. So those biomarkers are incredibly relevant. And again, this is also related, and they might be indicative of KRAS resistance to KRAS inhibitor, particularly KRAS G12C. So all this information are incredibly relevant. Opportunities. Again, I don't have the time to talk about, and this is a good news somehow. There's so much going on that I don't have the time to talk about everything. So I'm going to try to give you a glimpse of what is happening in the KRAS world, and then talk a few things, and maybe we might have time for a few questions later on. So we start with the what is new. And now, first of all, now we're talking about second generation KRAS. We know the KRAS is a KRAS G12C inhibitor. The first generation, so-called, are effective, though it's not a home run. Has been said, it's better than chemotherapy, but it's not, the usual result we would like to see, like an 80% response rate or really massively better than chemotherapy. Slightly better, but we want to definitely do more, and we definitely want to improve the results. And so moving, for instance, now we have new KRAS inhibitor. This is one of them. That is, I think, it's the one that is reaching the phase 2 trial. Probably is the first one is the divarasib. It's been developed by Roche, and we know there are studies ongoing. There are several studies ongoing, second and first line. We have also, this is a very interesting study to me, which that to compare. Is it divarasib better than sotorasib or better than adagrasib? This study, the B045217. It's going to try to answer the question. We all know that all these drugs have been shown good activity, but we need to compare, does the divarasib really different from the others? We'll see. And I think this is a very interesting study, but it's not the only one. We also have combination with the new inhibitors have been mentioned, like opnurasib, which is again a second generation KRAS G12 inhibitor, and again show quite interesting response rate. This is very early data. nearly 60% response rate, which is something quite, to me, impressive. Of course, this is not enough to prove the drug, but it's something very relevant. What is relevant is the toxicity and the activity. So can we combine this drug with something else? Is it a drug very effective? Because one of the limitations that have been mentioned that we might have with the actual KRAS G12C is they are relatively good or better than second-line chemo, but we don't feel they are good enough to be used in first line. Therefore, we need to combine with something else. But is it a combination too toxic? Because we know that there are particularly diarrhea and transaminitis. So the elevation of the liver enzyme is one of the concerns that we have with those drugs. This is another example of drug that was in the table presented before, glycyrrhizib. Again, quite similar in terms of response. Those patients were all heavily pretreated, so with first, second line. So this is just showing the activity of the drug with a response rate of 60% nearly, which means 6 out of 10 patients have a benefit. Now, it's relevant to know also the length of time of the benefit, but it's definitely some activity. And again, there are many others. I don't have the time to present them all. As you can see, the response rate is there. There are many drugs in development, and those drugs are going to be combined with something else, which is incredibly relevant, and we'll see whether they will change practice. I'm fully convinced that there might be room for those drugs, even in first line, if they're combined with a drug. I don't think at the moment none of this drug is able or could be used in first line on its own in KRAS G12C, but they should be combined with other drugs, either chemo, immunotherapy, or others. We'll see in a second. Now, this is another example of another inhibitor. There's some data from phase 1 study, the RMC 6291001 study, different doses, dose escalation. And again, it's a small group, but again, another drug that is showing some good activity and seems to have a good toxicity profile. So also this drug is something to keep an eye on. Now, as we said, we have, of course, KRAS inhibitor. They work pretty similar to the KRAS. They might improve the binding, of course, with the RAS, intracellular RAS, but how about the mechanism of action? Can we perhaps work on the so-called vertical inhibition? What does it mean? As you can see here, we have an upstream and a downstream. So the upstream is the part outside of the cell, downstream is the part inside the cancer cell, and therefore we can develop drugs that might have an activity on the upper part, so the upstream, as you mentioned, or we might even drug like the SOS inhibitor or the HP2 inhibitor. They might have an effect on the intracellular part or in the downstream part. There are plenty of them, from RAF inhibitor, MEK inhibitor, ERK inhibitor, so there are plenty. And again, this is happening because science is moving forward, and the fact there's so much interest around this, it's, in my opinion, and of course, I'm sure that Rosario agrees, it's good because there is science, there is interest, there are drugs in development. That means that there's definitely the possibility that some of this drug, not all of them, will reach the clinical state where we can then offer to our patient. And again, of course, it's early days. I'm not saying that any of this drug is ready for prime time, but it's good to see so many studies ongoing. Now, one example, a possible combination, which is one of them, is a combination the KRAS G12C with the SHP2 inhibitor. Again, combining two drug, could that be the way forward? And again, interesting, just showing some activity, response rate in the order of from 30 to 50%, very small cases, very different doses. Some were combined, as you can see, with sotorasib, some were combined with the new KRAS G12 inhibitor. As you can see, particularly, I want to draw your attention on the one at the bottom, where the response rate reached 77%, which is something, quite frankly, that I don't think we have seen quite often in this specific population. We need to, again, bear in mind, quite often patients with KRAS G12C are patients that are heavily smoker. So they're not patients we would expect a so-called target therapy to work very well historically. And now here we're seeing a 75, 77% response rate, which is unprecedented, in my opinion. Early days, but you know, I've got to say, I'm quite excited by seeing this data. How about the combination? Okay, so can we combine some of this drug? Can the toxicity profile of this drug, you know, give us the opportunity and let us combine them? There are some combination with the sotorasib and some immunotherapy. Now, one of the problems we do have if we combine the first generation is one problem particularly is the hepatotoxicity. So we have seen, particularly if we combine with immunotherapy, it doesn't matter necessarily which type of immuno. It could be, in this case, was either pembro or atezolizumab. You can see if you increase the dose of sotorasib, bear in mind that the dose for sotorasib is 960 on its own, though there are studies suggesting 240 might be as effective as, but you know, the standard dose is 960. You can see that the toxicity, particularly the grade 3 toxicity for the liver, seems to increase with the increase of sotorasib dose. So it's very difficult to combine, even if there is some activity, no home run, as you can see for the response rate, about 30%. So sotorasib, is it a good drug to combine with immunotherapy? I don't think so. And that's why this is a little bit of a blockage for sotorasib, but there are other drugs that might be combined with immunotherapy, and there are trials ongoing. I'm going to mention these in a second. How about adagrasib? Now, again, can we combine with immunotherapy? Again, there are different toxicity profile. As you can see, again, transaminase seems to be the issue. Transaminitis with increase of the liver function, with a grade 3 and grade 4, so severe toxicity that could reach even, as you can see, 10%. So it's something really, can be really relevant and can be quite concerning. Nevertheless, of course, the drug can work. This is particularly for PD-L1 more than 50%, where immunotherapy works very well. Difficult to say that adagrasib is really adding something rather than toxicity. So adagrasib, sotorasib, second line, perfect. Not sure those two drugs are really the way forward for the combination with immunotherapy. Now there are other combinations, and again, staying on the immunotherapy, as I said, there are new KRAS. They seem to be able to be combined with immunotherapy. Look at the olomorasib or the MK-1084. Those drugs seems to be combinable, we can say like that. And yeah, there is toxicity, it's undeniable. There is diarrhea, it's undeniable. Very good response, particularly for the first slides. You can see here for the olomorasib, 70% of response. So great activity, some toxicity, but it seems to be manageable. And I think that drug needs to be further explored in combination with immunotherapy. So definitely there are new compounds, particularly the second generation, that seems to be somehow more flexible in terms of combination with immunotherapy, where unfortunately the old, let's call it old, though they're not that old, the first generation KRAS are not that good with immunotherapy. And that's something that we all know. How about other mutation that has been mentioned? And this is one of the things I want to mention to you. KRAS is, we have KRAS G12C, but we do often end up, particularly when we do NGS, KRAS G12D is one of the mutations we encounter. And the good news is that there are also drugs that are going to be developed specifically to target this mutation. Very, very, very early days. I just want to mention a few of them. There are some pan-RAS. Of course, when you use a pan-RAS inhibitor, the response may be pretty good, as you can see from the RMC 6236. Toxicity might be a bit of a concern, as is a pan-RAS inhibitor. But again, there are now studies ongoing with second line and first line, the lung 101 and the lung 301, when they're going already to push this drug towards and against the docetaxel. And also there's going to be some study in first line where they're going to combine with immunotherapy, and we'll see. It would be great if we can really target the subgroup effectively. There is some activity, again, 40 patients, so, but some response rate. Again, we're starting from scratches, so we definitely need to accept that response rate will never be 80% at the beginning. Maybe we start with a 20, 25%. Maybe we can do better than chemotherapy a little bit, and then we might develop further drugs. This is how it works, in my opinion. There are other drugs, of course, in development. The RMC 9805, again, good activity, and there's a phase 1 ongoing. There are other drugs, and again, that's when I say there's so much going on that I think it's pretty much difficult to keep up with all the study. But if you look at the G12D inhibitor, I think that's going to be the second one. I'm sure this mutation is going to be cracked as the next one, in my opinion, on the list. And in a couple of years, I'm optimistic that we might see some good results, and we might be able to offer these, of course, in clinical trial at the beginning, because this is how science moves. But later on, it might even become standard of care, and that would be, in my opinion, fantastic. Bear in mind that the population for the KRAS G12D are slightly different from the KRAS G12C. It's not necessarily a heavy smoker, so it's a different population, and maybe the combination of these pan-RAS inhibitor or the specific also KRAS G12D inhibitor might be easier than the KRAS G12C. So again, it's work in progress. It will take time, but you can see from the publication, from the recent publication, there are different compounds. As I mentioned, the MRTX 1133, the HRS 4642. So many drugs in development. And this is, again, this is not, it's not, to be honest, there are many other combo trials ongoing. Today I just had the initiation visit for the Crescendo study, which is the first line trial when we're doing to combine a KRAS G12 inhibitor with immuno. It's going to be randomized towards chemo and immunotherapy treatment. And again, it is with the divarasib. But if you think about this, we're trying to get the chemotherapy out of the equation in first line. I think this is quite incredible, and we're doing so fast that I think we need to acknowledge how rapidly science is moving. And if you look at the list, there are, again, many drugs that are going to be combined. We say, if you look at sotorasib, they're going to try to combine with something slightly different, not necessarily with immuno. I don't think sotorasib can be combined with immuno, as I mentioned. And it's not dissimilar to what we're seeing pretty much with adagrasib, though they are trying to combine in the Crystal 7. I'm really curious to see the data, but also combined with many other drugs. As I said, some of them are acting on the downstream, and we'll see whether is there any way forward. But there are also many from the GDC onwards. There are many drugs. There are pure KRAS G12C inhibitor. They're going to be combined with other different drugs, ERK inhibitor, pan-KRAS. The MK1084 is going to be combined with immunotherapy. So there's a lot of really interest. There's a lot of trial ongoing. I'm sure some of them are, we all have some of the study. I have just mentioned one here. And I think we all are eager to really change the actual practice, because we want to offer more to our patient. Particularly at the moment, we're focusing on the KRAS G12C, but I'm pretty much confident that the next kid on the block is going to be the KRAS G12D. And pretty much at the end, or the kind of a very quick overview, because as I said, I think now there's so much to say, so many data, that I can spend really half a day talking about all the different studies where they combine with chemo IO and with chemo and the KRAS, or immuno and KRAS. Though the bottom line is with the definitely new KRAS G12C inhibitor ongoing, and I think the second generation are the way forward to move the drug in first line. In my opinion, I would be surprised if the first generation can really do that. And I think the toxicity profile in particular seems to be the way forward. There are many trials ongoing. Keep an eye on the KRAS G12D, because I think, in my opinion, is the new kids on the block. In a couple of years, I want to be optimistic, we might crack it, which is what we want. And that's why I refer when I say we might see light at the end of the tunnel, where historically, as has been mentioned by Rosario, when we had a KRAS G12C, or in general a KRAS, we would have said, oh no, we can't offer any target therapy. But these has been challenged as an assumption, and we can now say that we do have drug that can be effective, and that we're working hard to develop even better one. And with this, thank you for the attention, and I'm happy to take any of your question. I hope I give you sort of a glimpse, at a sense, of all the new treatment available in new trial ongoing. Thank you very much.
Thank you, Dr. Adeo, for this appealing and encouraging presentation. Thank you both for these presentations and for the information you have shared with us. We are sure that it will be useful, and our audience will be able to review whenever it wants in our YouTube channel. We have already received some questions that we would like to share with you, and you can give us your opinion and solve the doubts of the participants. We've got the first one. It's related to the conclusion talking about the KRAS G12C mutation. So what is the best treatment for KRAS G12 mutation so far? Sotorasib, yeah, is the only treatment approved in Spain at the present for this mutation. Could you inform us about its effectiveness shown by the studies? And is there any other study giving good results in KRAS G12C, and which one? Thank you.
So, Alfredo, if you want, I can take this.
Sure. I think it's pretty much a Spain one. Yeah, go.
I didn't know about Switzerland. So
it was withdrawn at the end of March 2024. We were all a bit disappointed, but it is what it is.
Yeah, it is. So in Spain, fortunately, we have sotorasib available. It has been approved, if I am correctly remember, at the beginning of 2024. It has it is available in all the countries, so it's excellent news. Adagrasib is still not, but I guess it will be approved pretty soon. As we mentioned before, Alfredo and myself, the activity of these two early agents, they are the first one, it's considered modest, although they have some activity in previously treated population. This is the setting we can use these agents nowadays in our current clinical practice. Patients who have progressed after a standard treatment, they can receive this targeted agent. So we are trying to move these new agents to the first-line setting and even to earlier stages, but it's not approved so far. We don't have any trials that with positive results and with approvals from the agencies that allow us to use these agents in other settings than previously treated population. Correct me, Alfredo, if I am wrong.
No. You're totally right. And again, I think we need to put things in perspective. As we said, we're talking about a mutation that was undruggable until a few years ago. I don't think we would have imagined 4 or 5 years ago that we could offer tablets to patients with this specific mutation. Now we're all fully aware that we definitely need to raise the bar, and that's why it's good to see there's a lot of study ongoing, but those are studies, and to change practice, we definitely need to have positive phase 3 trial. And even sometimes if we positive phase 3 trial, drugs can be withdrawn depending on other situation. So
it's very complex.
It is complicated, but as has been said, I think if you have access to either sotorasib or adagrasib, it's fine. I don't think we can claim that one is necessarily better than the other.
No.
They are pretty much equivalent as far as we know, but as long as we have access, I think this is good.
Yeah, fully agree.
Okay, thank you. We've got another question. It's about any progress in KRAS G13D treatments.
I can answer that for G.
Yeah, sure.
Yeah,
sure.
for the KRAS G12D. The answer is, as I mentioned, and this is for me the most exciting thing, because with KRAS G12C, of course, we're working on it, but the KRAS G12D is completely different population, and so far, couldn't offer anything. I have a few patients with that, and I always wonder how cool it would be if I could offer some target therapy, and I think things are moving forward now. In terms of timeline, the KRAS G12D development is slightly behind the G12C, but it's coming. And now there are phase 1 study ongoing with some good results. Again, I don't want to sound too optimistic because the results are not overwhelmingly good, but there is some activity, which is the first step. And then maybe those drugs need to be combined with something. It could be highly, chemotherapy, probably. Then might really change the situation and give us the opportunity to offer this drug. But we are far behind. It's not going to be available at least for a couple of years, perhaps even longer. But trials are coming. And we know that the first step is getting access to trials to expose the patients as soon as we can to these and to move research forward. So I think there's going to be the next kid on the block for me.
Okay, talking about trials, we've got a question for you both. What do you think about the amount of time a country has to wait in order to be ready to use a drug when it's been already approved by the FDA? Like a debate.
Who goes here?
I can go. I don't mind. I mean, we're comparing apple and orange. It's a completely different system, and the FDA has a way of getting access to the drug quicker with the early approval, accelerated approval, whatever we want to call it. But then they might be withdrawn from the market. It's completely different. The EMA has a different approach. and the whole system, the whole health system in Spain, but in Italy or in France or in UK is pretty similar. It's not private sector. There's no, private insurance. So I don't think we should speed up the process per se. We definitely need to have a bit, in my opinion, I wish you could have a bit less or fewer Me Too trial. Like the trial that we have 4 trial, and we've seen these with drugs very similar, showing pretty much some results. And therefore, this is a bit of a waste of resources, in my opinion. But speeding up the process, I'm not sure I would like to use the FDA attitude because it's a different system, personally. But
yeah, I fully agree with you, Alfredo. I think access, it worries a lot, all of us. I understand patients worry, but also for us, sometimes it's frustrating. But I think we need to be very cautious when we talk about access. And the process should be also based on evidence, because at the end of the day, this is a balance between what the drugs can offer and what the system should offer. So now we have a huge amount of new drugs in development. I am fully agree. We don't need many two drugs. This is not the way to move forward. We need to raise the bar, what we already have. And this is something that needs to keep in mind. All of us needs to keep in mind this. Access is always a matter of worries, but this, I don't like, I really don't share the system, FDA system. I'm fully agree with Alfredo. And just a brief note, in Spain, we have a delay compared to other countries in Europe. It's completely true, but it's also true that I would say the last couple of years, we have improved a little bit this access. So again, nothing is not everything is perfect, and many things needs to be improved. But I think that if we work together, physicians, patients advocates groups like AEACaP, we can get better access, but keeping in mind that this needs to be very cautious process.
I agree.
I agree too, and I think AEACaP and other association and patients have to advocate for lung cancer. We've got the last question. Is how do you see KRAS patients' future with all these oncoming treatments and the importance of trials?
Well, I think it's time to optimism. Probably is one of the most crowded therapeutic scenarios we have in the field of lung cancer. We have many trials ongoing. We have many approaches. We have different drugs. As Alfredo mentioned, G12D, it's really appealing. But having all these trials ongoing is also a nice opportunity and a great opportunity for our patients, because we don't have approvals and we don't have these agents in the market yet. But having access to trials, for me, is always an open door. It doesn't mean it's the solution, please. I think also we need to be very honest. Sometimes a clinical trial, unfortunately, is not the solution, but it's an open door.
I couldn't agree more. I think that definitely it's good that there are many trials, which means there's a lot of interest, a lot of research, and we need to understand that behind this drug development, there are very smart and clever people working in the lab to understand somehow biology, because the reality is now today we can use a certain drug because somebody got how potentially could work and what was the mechanism of cancer growth, which is pretty much similar to what happened with the very famous EGFR. But at the beginning, we didn't know, and then somebody realized that there was a mutation that codified for a specific tyrosine kinase domain. So this is the base. So the fact there's a lot of trial means there's a lot of research behind, means a lot of interest, and I'm sure not all the trial will be positive for sure, but there are going to be some drugs that might be able to change the actual situation. Where I see the future for the KRAS G12C, but I see, and I'm hoping to see a future where we can use it in first line, but the only way to use it in first line is by combining it with something. I don't think KRAS G12C, even second generation, are ready for prime time on their own. They need to be combined, and they need to find the right partner. And this, the reason why it's so complicated is that our first line, to be honest, is not too bad. With immunotherapy, with the chemoimmunotherapy, we know that the patient with KRAS G12C might benefit from immunotherapy. So the bar is already high. For the KRAS G12D, of course, it's a different story. And we're at the very, very beginning. But the fact that there is an interest, the fact that they're working on, the fact they're moving things forward and with research makes me really optimistic. And again, I totally agree. Having trial per se means nothing, but having, you know, several trials when we believe we can really offer something new and better to the patients, I think this is really of great value. And there's no way we can move science forward and change practice without trials. This is something that, of course, we need to understand.
Thank you. Unfortunately, we have no more time for further questions, so we are going to close today's session. I didn't want to finish without repeating my thanks, first of all, to Dr. Garcia Campello and Professor Adeo, on behalf of myself and the people who are part of the association, for the time you have dedicated to us. I would also like to thank the industry that made today's webinar possible, and last but not least, the participants in this activity. Many thanks to everyone, and see you at the next webinar. Thank you very much.
See you.
Thank you.
Thank you very much.
Thanks. Many
Cheers.
thanks. See you. Bye.
Bye.